This is Mon Health Talk, a weekly program focusing on the dedicated physicians, nurses, and staff at Mon Health, the region's premier community hospital system. People with skillful hands and bright minds using state-of-the-art technology. We don't just practice medicine, we care for people like family. That's why at Mon Health you can feel the difference. Once again, welcome to this edition of Mon Health Talk.
Good morning. Welcome to Mon Health Talk. I'm Dave Wilson. Our guests this morning are Dr. Kristin Statler and Dr. Mark Johnson as we continue our focus on Breast Cancer Awareness Month. Dr. Statler, good morning.
Good morning.
And Dr. Johnson, good morning.
Good morning, Dave.
I appreciate you guys coming on. We are in the middle portion of our programs on Breast Cancer Awareness Month. Mon Health's Breast Cancer Detect It. Today we'll talk about Treat It, and next week will be Defeat It, the Detect It, Treat It, Defeat It campaign. We'll get into treating breast cancer in just a moment. But first, you guys know how this goes. You must talk about yourself, and you must talk about something you've not talked about in your previous appearances on the show. Going to make this more difficult for you. But first of all, eeny, meeny, miny, mo, Dr. Statler, just give folks a quick background about where you're from, where you went to school, how you ended up with Mon Health.
Sure. So this one's an easy one for me. I am from Morgantown originally, actually the western end of the county. I went to Clay Battelle High School and then went to undergrad and medical school at WVU. I did a residency at CAMC in Charleston, and then I wanted to come back home to be with my family. So that's why I chose Mon Health. I was born here, and I love working here.
And what's your specialty?
General surgery.
All right, Doctor. Go ahead. Oh, all right, Dr. Johnson, go ahead. Same thing, your background.
Okay, so I'm going to make a confession, Dave, that I'm sure is going to stay just between you and me.
Okay.
Because last weekend, I went to the Morgantown High School football game to celebrate the 40th anniversary of my football team winning the state championship in 1983.
Awesome.
So we had a great event. It was a wonderful event. We had a great tailgate, and the game didn't quite turn out like we wanted it to, but it was great to see a bunch of guys and rekindle some old memories. Like Kristin, I'm a Morgantown native, born and raised here, went away and did all my schooling out of town, and then came back for the same reason. I love my family, love this area, and wanted to practice medicine here with my father and live in Morgantown.
And what's your specialty?
Also a general surgeon.
All right, both general surgeons. And just by the way, how many of those guys at that reunion last week could strap them up for maybe a play or two?
Well, we all knew we had one or two plays in it. We knew that. The question was how many until we were all carted off.
Yeah, if you guys went back out there, you might see Dr. Statler. You might see some of those guys on your operating table if they went out there and tried to strap them up a little bit. All right. Well, guys, I appreciate you joining me here on the program this morning. As I mentioned, October Breast Cancer Awareness Month, and Mon Health has the Breast Cancer Detect It, Treat It, Defeat It campaign. So we'll start with you, Dr. Statler. Just kind of give us a general idea how the oncologist and the surgeons work together to treat breast cancer.
Absolutely. So most importantly is we start out with the mammogram, and once we have an abnormal mammogram, either your primary doctor or your oncologist or your gynecologist will send you to either the general surgeon or to the oncologist, and immediately we start communicating with this abnormal mammogram what needs to happen next. Usually it's a biopsy, and then we talk about what type of biopsy needs to be done. In the event of a positive biopsy, oncology and general surgery meet. We discuss types of treatment, what's best in the scenario that we're facing for treatment, and the patient often sees the general surgeon and the oncologist within a week of one another to kind of make a plan of how you individually want your treatment to go.
And Dr. Johnson, as you're having those discussions, can you give us an idea of the variables that you take into consideration when coming up with a proper treatment plan?
Yeah, so what I share with my patients nowadays is that I look at the management of breast cancer as being a multimodal treatment plan. There's surgery oftentimes, there's chemotherapy, and there are a variety of different kinds of chemotherapy, and there's radiation therapy. And what's great about that for the patient is that with those multimodal approaches, we are achieving success rates and cure rates and so forth that we've never seen before. And so it's a little intimidating from a patient perspective to hear that, but at the same time knowing what the goal is and realizing how successful we are, it can be very reassuring. What I tell everybody is it's not so much a matter of what happens first as much as it is what's the best plan overall and how do we coordinate all different modalities to make sure that we're doing the right thing.
And Dr. Statler, how do you coordinate with, obviously there's the oncologist, there's a whole team, and I want to stress that it's not just one physician, but there is a team who are coming up with a plan here for the patient.
Absolutely. And one way we coordinate is something called tumor board, where we meet and discuss the individual cases. I mean, we keep patient confidentiality in those scenarios, but we discuss the case as a group to come up with the best way to treat the cancer. Another way we coordinate is simply picking up the phone and a good old-fashioned phone call about what you have and what needs to happen next.
So can you give us, and obviously stress this, each patient it's a case-by-case scenario. There is no one-size-fits-all treatment plan. But Dr. Statler, can you give me a general idea of how a treatment plan would go or what a treatment plan would consist of?
Absolutely. And I think you really do have to stress that it's an individual patient choice. So in most situations in breast cancer, we have breast conservation therapy versus mastectomies, the old-fashioned take the entire breast. Breast conservation has come a long way. So in most patients, that's a great option, and it's minimally invasive in the fact that they get to keep most of their own tissue. However, I talk to every patient and tell them that it's an individual choice as to what they want to choose for their treatment. In the situation of breast conservation, which is a very popular choice, oftentimes you have treatment started with surgery. You do lymph node evaluations and then follow up with radiation therapy, and then plus or minus the chemotherapy depending on the type of cancer and how invasive and large it was. So overall, when we start the treatment process, meeting with the surgeon to the finish of the treatment, I tell patients expect about a 6-month process. Dr.
Johnson, what role does your family history play into the treatment options?
Well, there's two things. The first thing is, first of all, overwhelmingly, most women that get breast cancer have what we call sporadic breast cancer, meaning it's not related to a family problem or an inherited genetic disorder. But unfortunately, the presence of breast disease in the family does increase your risk, even if you don't have a BRCA mutation or some other genetic disorder. So that sort of informs us a little bit. For example, if we see a patient who's got an abnormal mammogram and we're not sure and we don't know what to make of it, but mom had a bad family, had a breast cancer, that might motivate us to be a bit more aggressive or to be, to go forward with a biopsy when we're discussing our options.
Dr. Statler, has family history played a role in patients' decisions to, go ahead with a mastectomy versus other procedures?
Absolutely. I think a lot of patients come in with their mind kind of already made up. Most of our patients are extremely educated before they even get to us because Google is just an amazing doctor. So what will happen is they'll come in with us and they'll say they already know about their options and they're interested in a mastectomy because their mother or their sister and their grandmother all has cancer. And I'm okay with that, and I tell patients it's individual choice, but I also encourage genetic testing in cases where it's appropriate because that can help lead your decision. If you know genetically there is a gene that's going to increase your risk of breast cancer versus a completely run-of-the-mill variant, if you will, that has no genetic tie.
Before we take the break, you brought up something there I'm curious about. I'll pitch it to Dr. Johnson. Are patients better informed of procedures and options before they ever get to you, or do they also come in with misconceptions because they consulted Dr. Google before coming to see you?
Well, I tell you, that's a great question, Dave, because here's the challenge. what's the great thing about managing breast cancer today in this community is that we can offer very specific treatment plans based on the particulars of your cancer. And the challenge really is that when you tell Sally at the grocery store, or when you consult Dr. Google, you're going to get some advice, but you may not get the kind of advice that is as totally focused on what your problem is, and that can create a challenge, because then when the patient, we sort of have to start the process all over again in terms of education and understanding. And I think the smarter you are, the better you can manage it. There's no question about that. So I encourage you to know fully what you're dealing with. But it is a challenge, because the treatment plan for somebody else is not necessarily the right treatment plan for you. We can offer you, a very streamlined and focused treatment that's best for what is wrong with you.
Our guests this morning, Dr. Kristin Statler and Dr. Mark Johnson. We're talking about treating breast cancer as part of Mon Health's Breast Cancer Awareness Month campaign. Detect it, treat it, defeat it. We'll continue the conversation right after this. You're listening to Mon Health Talk on WAJR.
Now back to Mon Health Talk, a discussion of the issues, people, and procedures in healthcare today. If you have a question for one of our healthcare guests, call now at 304-296-0041.
Our guest this morning, Dr. Kristin Statler, Dr. Mark Johnson, as we talk about Breast Cancer Awareness Month, Mon Health's Treat It, Detect It, Treat It, Defeat It campaign. Got them in the wrong order. It is the Treat It portion of that campaign we're talking about this morning. And we'll start with Dr. Johnson this segment. Dr. Johnson, can you talk a little bit more about what procedures are available and what they're trying to accomplish when it comes to treating breast cancer?
Sure. So as Dr. Statler referenced a second ago, that almost everybody nowadays starts off with a biopsy. Driven by an abnormal mammogram or an abnormal ultrasound, or maybe a physical finding. Those biopsies are minimally invasive. Nobody likes to come to the hospital. Nobody likes to get a needle stuck any part of their body, but it's a well-tolerated procedure. And oftentimes that gives us clarification. Hopefully it means that there's no additional intervention necessary, but sometimes it does push us to talk about additional intervention. Overwhelmingly, most women who are diagnosed with breast cancer on the basis of a biopsy will have surgery first. That's not 100% true, but most women will. And the surgical options, as we talked about briefly a minute ago, are two. There's a partial mastectomy, also called a segmentectomy or a lumpectomy, and that's essentially an operation where you make an incision and go into the breast and remove the area where the cancer is. We always struggle to make sure that we removed all of it and that we've got what we call clean margins. And then that's it. And that's somewhere between a 2 to 3 inch incision on the breast. It's it's done under anesthesia. There is, of course, some discomfort associated with it, but most people do very well with that. And that's contrasted with a mastectomy, where the breast in its entirety is removed. That obviously is a bit more of an operation that requires a bit more time in the operating room and a bit longer of a recovery period. The other thing to mention is that, again, overwhelmingly, most patients who have breast cancer will have a biopsy of lymph nodes as a part of that operation. And today we use a technique called a sentinel lymph node biopsy, which in comparison to the old-fashioned techniques is much better in terms of patient tolerance and the risk of complications. So all of this is sort of focused on how do we do what needs to be done with minimal disruption of the patient's life and ability to do their chores and carry on with everything else that's important to them.
And Dr. Statler, how quickly does this all come together? Say from the time something abnormal is detected in the mammogram, how quickly does a plan develop and then we start to move forward here?
So each patient is individual. I always tell patients that usually from the time of abnormal mammogram to biopsy, we try to make that less than a week and usually have results within a week of that biopsy. From there, I want you to see me within another week. So all total from the time of abnormal mammogram to seeing me, it should be within 2 weeks, if not sooner. And then we discuss surgical intervention, and if we're going straight to surgery, I want that to happen within 1 to 2 weeks. Given the scenario, whether or not they need genetic testing, that might be slowed down a little bit. If we have genetic testing that has to be sent off, sometimes we have to delay surgery until we get that testing back, because that could potentially change the treatment options.
Dave, I'm sorry.
Go ahead, Dr. Johnson.
Dave, let me add into that. So, we've talked already this morning about the importance of coordinating care and the importance of the surgeon and the oncologist and the family doctor. Everybody works together to do the right thing for the patient. And I think certainly from a patient perspective, there's a lot of anxiety. And so their opinion is oftentimes, well, let's get this done immediately. And I say to them that what's more important is that we work out a plan that we can all agree is what's best. And so taking a little bit of time, taking a week or two to work out coordinate the appointment, get the biopsy results. There are specific details about those biopsy results that take maybe 10 to 14 days to get. Knowing all that information before you make a definitive plan is ultimately in the best interest of the patient. Doesn't do a lot to solve their anxiety, but is better for the treatment plan. And so being careful and thoughtful and making a good plan is a lot smarter than rushing into doing anything. And so we try to certainly, we don't want to make people wait any unnecessary amount of time, but providing them the best care is more important than providing them hurried care.
Still seems like a pretty quick timeline. We're talking, a matter of 6 weeks in total in most cases there, it sounds like?
Yes, usually within 6 weeks we've at least started the treatment process, depending on what treatment goes first. And we try to do that as quickly as possible for patient comfort. But Dr. Johnson's absolutely right. Sometimes you have to plan your race before you can run it. And so we always want to make sure we have a good plan in place before we start the process.
I'll give you both a shot at this question. It's what are the most common questions when you're consulting with a patient prior to a procedure, prior to a surgery, that they have for you? I'll give you both an opportunity here.
I think the most common question that comes to mind for me is always, when can I go back to work, or when can I go back to what I want to do? And so we have a realistic discussion about what the surgery itself entails and how they're going to feel afterwards and expected post-operative outcomes, so that they know really what can happen and what they're looking at long term. Everybody just wants to be able to go about their life, so we want to make that as smooth as possible, I think.
Dr. Johnson?
My answer to that question, Dave, is I think a common question that I get is, do I have to have a mastectomy to take care for my breast cancer? And the answer is, as Dr. Statler alluded to a few minutes ago, overwhelmingly, most women have a choice between breast conservation or the partial mastectomy that we talked about, or mastectomy. And so obviously everybody is different, so there's no 100% in any of this, but most women do have a choice. And that choice has nothing to do with sacrificing their potential for survival. I think a lot of women say, well, if I have to have a mastectomy because it's the best thing for my health, I'll have a mastectomy, but I don't want one. And overwhelmingly, we can reassure them that that's not a necessary decision on their part, and that a mastectomy is an essential to the treatment. And so that can be very reassuring.
Guys, the half hour has flown by. I want to remind everyone that 3D mammograms are available through Mon Health in Morgantown, Fairmont, Grafton, Weston, and Kingwood. Visit monhealth.com/mammogram to schedule. And you can always learn more at monhealth.com/general surgery. Dr. Kristin Statler, Dr. Mark Johnson. Guys, thank you so much for taking some time this morning.
Thank you.
You're welcome, Dave.
Absolutely.